All right, we are going to get started. Hello, everyone, and welcome to the 2022 PI Conference. My name is Alyssa Creamer, and I'm the Director of Community Services at IDF, and I will be your moderator for this morning's educational event. This morning, Drs. Yael Gurnez and Ami Shah will be presenting on the topic of interdisciplinary care teams and the relationship between your providers. There will be time for questions at the end of their presentation, so please submit any questions you have for these presenters via the Q&A feature on the Cvent platform. This morning, we welcome Dr. Ami Shah, Clinical Professor of Pediatrics in the Division of Hematology, Oncology, Stem Cell Transplantation, and Regenerative Medicine at Stanford Medicine Children's Health, and Dr. Yael Gurnez, Clinical Associate Professor of Pediatrics in the Division of Allergy and Immunology at Stanford Medicine Children's Health. Dr. Shah and Gurnez will begin the presentation with a short PowerPoint overview of their roles as immunologists and transplanter and some case journeys that exemplify how they collaborate on patient care. Welcome, Drs. Shah and Gurnez.
Thank you very much, Allison, for having us today. Good morning, everyone, whatever time it is, wherever you're at. So what we want to do today is kind of go through some scenarios of how you get diagnosed with a primary immune deficiency, and then what our roles are as the transplanter and the immunologist. Now, I just want to point out that this may be different from one institution to the next institution, but we're going to hopefully give you some tips of how you can make your process easier for you to understand. Because really what we want as providers is to make sure you understand what's going on, you know what the next steps are, and you feel empowered to ask all of us questions about what's going on. Okay. Whoa, let's see, hold on. Okay, so I'm going to start off with a couple of different cases, and then we'll go through what happens with them. So the first case is a 4-month-old male who was seen in the emergency room and is noted to have 3 things. One is failure to thrive, which means he was less than 5th percentile for his weight. He had thrush, who's working really hard to breathe, which is like 50 times a minute, which is very fast. And so his chest was going up and down. And the hospital team was called because they suspected a primary immune deficiency and consulted Dr. Gurnez and the immunology team. So what are these terms? When you hear these words, most of us don't know what things are. Thrush is as oral candidiasis, okay? Candidiasis is a little fungus, and many people can get that, okay? That in and of itself doesn't mean you have a primary immune deficiency. But thrush is an area where you have, on a normal tongue, you don't have all these little white spots, but on this mouth, you have white spots right here. Okay, and you will really have it up in the buccal mucosa, which I can't get a good picture of always, but back here is where we would see that. Okay, that's the first thing that's called thrush. The second is something called failure to thrive. And what you can see here is a normal weight for a baby. It goes along this growth curve, and these growth curves were developed many, many years ago with farm children. So it's oftentimes quite high. And what you see on this particular baby with a primary immune deficiency, he was growing and growing and growing, and then he just stopped growing. And you see how it becomes flat. When we say failure to thrive, that means they're falling off of their normal trajectory. They're no longer going on this dark line. They're coming off of it and going to below 5th percentile. And so when we say failure to thrive, they're oftentimes they have a weaker cry. They don't, their skin tone, which means they're not as vigorous. They don't oftentimes have good skin turgor, which means when you pull up their skin, it's not as plump and thick. They don't have as many wet diapers. They oftentimes can have, they don't feed as much. They don't seem to they get tired when they're feeding. All of those things are what we mean by failure to thrive. And in terms of the respiratory distress, this is the chest x-ray that was done in the emergency room on this little child. He was breathing, as I said, 50 times a minute. Normal children, babies will breathe about 20 to 30 times a minute at the most. But 50 times a minute is double that. So they're breathing really, really fast, really, really shallow. They'll have what's called low oxygen saturations. For normal babies, they should have greater than 95% oxygen saturation, which means all the red cells are able to take up oxygen. And on this particular child, he's not getting enough oxygen in, and that's because there's something going on in his lungs. Now Monday morning quarterbacking. I wish I'd put a picture of a normal chest X-ray on here. This is the heart that I'm outlining right here. But all this white stuff right here, it looks like little spread out cotton balls. That's what we mean by ground glass infiltrates, which is suggestive of an infection going on in the chest. Okay. And when we see all those things, the first thing that clicks in most of our minds is something's wrong with this child. It's probably an immune deficiency because he has 3 classic features of an immune deficiency. Now, I'll just point out that not every immune deficiency is the same. There are many of you that may be on the call today that have a child with SCID, but other people will have a child with Wiskott-Aldrich or with chronic granulomatous disease, or you may have a child who has an illness that they haven't identified yet. In this particular situation, I'm just talking about patients with SCID in terms of a criteria of primary immune deficiency. Okay, so what do we do then? I'm going to let Dr. Gurnez talk about this particular thing, which is when in the emergency room, they would probably, if they saw this patient, besides admitting them to the hospital, the team would then order an immunology consult to work out a primary immune deficiency. And I'm going to let Dr. Gurnez go over this and to say what kind of tests she's going to order for you to help her make the diagnosis.
Good morning. So yes, when we see this patient, it's exactly like Dr. Shah mentioned, with very thrive as well as with very likely opportunistic infection that might happen in a host that has something wrong with his immune system, then we usually get consulted. And I think the emergency is we need to try to get to the diagnosis, because as soon as we have a diagnosis, as soon as we will know what type of treatment we can give the patient. So the first thing first, which is often not done by us, is a regular CBC, which looked at your hemoglobin, the thing that transport oxygen to your body, platelets that help you to coagulate, and white blood cell. And the white blood cell are the things we're really looking into, because that's the cell that defends you against infection. But then if we take a big microscope and look at the different population of white blood cell, that's called an apophytic screen. So it's just to go deeper in this population. And when we do it in this child, we realize that it has no T cell. So I don't know if you're very familiar with immunology, but T cells are very important to help to defend yourself against viral infection. B cells are very important to defend yourself against bacterial infection. Often B cells need T cells to work. They work as a team. And K cells are important for cancer cell or tumoral cell, as well as viral. So in this child, there is no T cell, which is it's an emergency. It's very problematic, because if you don't have any T cell, you cannot fight an infection. And remember, your B cell cannot work either. So you have someone who cannot fight an infection via his immune system. B cell can secrete antibody or immunoglobulin. Same word. So if you hear immunoglobulin, it's the same thing as antibody. It's the same thing as IgG. There is different type: IgG, IgA, IgM. IgM are usually the naive one, the one have not seen anything. IgA are usually new mucosa, and IgG are the one that have some memory. They already have seen something and they remember it. IgG are low, but even then, even if he has some immunoglobulin, he might not be able to work very well to fight an infection, because he doesn't have any help from the T cell. Here, we still look at the T cell function, but if you don't have any T cell to start with, it's like a sport team. If you look at a soccer team, I'm not very good with sports, so I'm going to say number. Let's say they have 11 players in their sport team. If there is 0 player, then they will not be able to play well. So if you don't have any player, the quality will be very poor as well. Quantity and quality are poor. And then we definitively, in someone who doesn't have any T cells, sometimes they might have the T cell from their mother, and that's usually not a good thing. And so we often check, when you have no T cell in the child, that there is no T cell coming from mom, because it might not be helping the child. It might be actually having very serious consequences. So when we see that, we have a diagnosis of severe combined immunodeficiency. And the main goal, and we will see on the later slide, is to protect this child against infection, which in this case, we have to treat the infection. But in general, we're really trying to protect them against more infection. And we need to work very quickly to identify what is the genetic mutation in order to be able to talk to Dr. Shah very quickly and see what will be the best definitive treatment. So we, at the same time that we're looking at his immune system, we definitely do a genetic workup that takes about 2 weeks to come back now. So we try to go as fast as we can. And in this child, he had a mutation in the L2R gamma, which is extremely important for the T cell development. And so they could also have sometimes an absence of NK cell, but if you have a gene, a mutation in this gene, then you don't have any T, and sometimes you don't have any NK. And that's why this gene is so important for the T cell development, that if this gene is mutated, you're not going to have any T cell. So it's called SCT, severe combined immunodeficiency. I think that's it for his slide. Yep. Oh, Amy, you're muted. Sorry.
So the second case we want to talk about is something that's happening more frequently. It used to be we didn't have newborn screening, and these patients would be healthy, and then all of a sudden they'd come to us being very sick with oftentimes this respiratory issue that we just talked about. Nowadays, though, everybody in the country every baby is being screened on the newborn screen for severe combined immune deficiency or for an immune problem. Some patients don't have primary immune deficiencies when they're screened, and that's part of what we're going to talk about next. So the next case is a 2-week-old that was perfectly healthy appearing, first child, and there was a positive screening test for SCID. That test is sent to their primary pediatrician, and the primary pediatrician will get this newborn screening report that says, hey, this patient has no what's called TREC, which is the new T cells that should be happening in every person. And so they will call Dr. Gurnez and say, hey, I have a patient who's positive on the newborn screening. When can they get in? And Dr. Gurnez will get you in pretty quickly. There's no family history, so the family has never heard of this word SCID or any immune deficiency. And the baby's doing otherwise well, eating and drinking, mom's breastfeeding, which is what most people will do when you have a brand new baby. But due to the positive newborn screening, the patient is referred to a primary immune deficiency center for evaluation and confirmation. In the state of California, many of the large centers will have a primary or are a primary immune deficiency center. All of us there's a very small population of physicians that take care of these diseases. We all talk, we all work together. We all know the different trials that are out there, and we will really work hard to try to establish a diagnosis and to get you to the right place for the right therapy. Okay, whoops, what did I do? All right, so when we talk about the consideration, case 1, as we talked about, is sick. They have respiratory distress. They probably have an infection. These patients are usually managed in the intensive care unit or by the pulmonary team to treat the respiratory symptoms. And that is a number one thing, because yes, we need to establish the diagnosis, but the primary thing that we need to really do is get rid of their infection to get them to a stable enough situation before we can get a definitive therapy. Immunology and stem cell transplant are oftentimes consulted simultaneously at the same time. So let's say in case 1, the patient's sick, they're in the ICU. They'll have an ICU doctor who is the person managing the day-to-day, the infection. They may have a pulmonary team, because we know that patients, when they're that sick up front, they may end up needing long-term respiratory care. So oftentimes pulmonology is also involved with them in case they still need to be on oxygen when they get to the floor. Immunology is consulted because we need to figure out what's wrong with this baby. We need to figure out what illness it is, so we can figure out so when we do the stem cell transplant, we know what we're treating. Okay. In the second case, though, really the baby's healthy. The baby's perfectly fine. They're going to be seen in clinic by Dr. Gurnez and her team. And then we're going to try to get the lab tests done to figure out what the diagnosis is. Some people will have a false and positive newborn screening, and we have seen that. Sometimes it improves and there's nothing wrong with the baby. Sometimes they have something different than SCID, okay, or some other T cell abnormality, but doesn't necessarily need a transplant right away. So there's a lot of different possibilities. as we talked about, newborn screening is just that. It's a screening test. It tells us there's something that's not right at the time the baby's born. Sometimes premature babies will have a positive newborn screening because their immune system isn't developed. And when over time, as they get older or get to the time when they should be born, things will improve and we don't need to do anything more. Okay. So various things will happen, but that's why we have the immunology team involved up front so that they can really help establish who needs more therapy, who needs to be just monitored closely, and who needs to just go back and go to kindergarten and live their life. So as I said, immunology will do the initial workup. They will not consult stem cell transplant right away because we won't have anything to say to the family because we don't know what the diagnosis is. If the patient really has a primary immune deficiency, such as SCID or Wiskott-Aldrich, then they will refer to stem cell transplant. If a patient has something like CGD, we won't get referred as stem cell transplant right away. They might let us know, but if a patient with CGD won't necessarily come to transplant unless they start having infections that tell us, hey, this patient really is sick enough that he probably isn't going to have a good quality of life unless we do something more definitive. Okay, so I'll let Dr. Gurnez talk about what is it that immunology does when they get consulted.
So first, I'm just going to repeat what Dr. Shah mentioned to you. We are a center of reference for newborn screen result for severe combined immunodeficiency. So every time there is a positive screening test, we receive a call. And exactly like Dr. Shah mentioned, it is just a screening test, right? So we often, unless this screening test is zero, I mean, there is zero track, I mean, there is probably no T cell, we usually really want to wait for confirmatory tests to make sure that we are dealing with potentially SCID. So if the test is zero, we might act on it right away. If the test is positive, but a little bit low, exactly like Dr. Shah mentioned, I don't want you to be worried right away. It is a screening test, and there is a lot of differential. But our job is really to confirm that this test is not a false positive. So let's say we do another blood test that usually is sent by the primary care doctor, and it's the one that we talked about previously. It's to look at exactly how many T cell the baby has. Are the T cell is or is mother? And then how many B cell and how many NK cell. And we have usually this result in 2 days. This thing is faxed to us and we see it right away. And based on the number, the exact number of T cell, the exact number of T cell in the baby, the exact number of B cell and NK cell, we usually decide if, yeah, don't worry, it was just a false positive, or if there is no T cell at all, then it's an emergency. We'll see this child within a few days, usually the next day. Or if it's in between, we're going to start following this child and see exactly like Dr. mentioned, if there is no SCID, but maybe something else will come out and we need to monitor over time. Let's say we confirm that the baby has SCID with the secondary blood test. Then the first thing is, like Dr. Shah mentioned, a lot of new mom are breastfeeding, and we have to ask them to stop and pump. The reason for that is we're really trying to prevent any infection. We want to have the baby in a bubble. And as you may know, most of us have encountered CMV, cytomegalovirus, which is a virus that is everywhere. So most of the population is positive for this virus. And the thing is, we don't even know it, and it's not a problem for us. But if you pass that to your baby through the breast milk, then it could be an issue for the baby, because the baby who doesn't have any immune defense will get a severe infection. So I know it's a hard discussion we have with the family, but sometime even before we see them, we ask for the mother to stop breastfeeding and to pump her milk while we're trying, of course, to give like powder until we figure out what's going on. So don't be surprised. That's the reason why. It's to really protect the baby. We have many goals. One goal is to prevent any infection. So of course, it's to stop breastfeeding in mother, but it's also to start to prevent infection by giving medication. So we try to give something against bacteria, which is called Bactrim, that we won't start before 3 weeks of life. because it needs to be eliminated through the liver. And so we will start at 3 weeks of life. We need to have something against the fungal infection. And Dr. Shah mentioned to you Candida thrush. So that's why the baby will be started on fluconazole. And often we try to treat, there is not an amazing treatment for CMV, but we're trying to prevent it. And acyclovir is one of them. So we're really trying to prevent infection by asking mom to stop breastfeeding. 2, by having this medication. And 3, remember I told you, if you don't have any T cell, you don't have any functional B cell. And so you don't have any functional antibodies. So then you need to help the child to have antibodies from other, right? We do everything to prevent an infection. So we'll start immunoglobulin replacement therapy if his numbers are a little bit low. And immunoglobulin replacement therapy is immunoglobulin. So it's a pool of donor. And I think it's a great thing that it's a pool of donor, because the more donor you have, the more diversity in the antibody you will have, right? Everybody has experienced different infection. Everybody had maybe different vaccinations. So I compare the immunoglobulin from donors to a library of books. The more donor, the more different books you have in your library, and the more different books you have in your library, then the better you're protected. And I want to say, because I mentioned infection, you don't have to worry about the transmission of HIV, of hepatitis. It's extremely safe from that standpoint. So it's just a plus. So again, the first thing first is, 1, as soon as we confirm the diagnosis, we really want to protect the baby and put it in a bubble. By that, 1, we ask mom to stop breastfeeding, which is difficult. 2, we protect him or her with multiple prophylaxis to prevent an infection. And 3, we give him antibodies from mother if the antibody level is a bit low. But that's only one part. I think the most important part as well, where we're trying to prevent an infection, is really to identify the cause. Can we identify one gene in the genetic program that is responsible for that? And that is very important, because that's when we can contact Dr. Shah and her team in order to say, we have this kid who has kids secondary to this mutation. I think it's time to discuss about stem cell transplant. But to be honest with you, what you don't know is sometimes from the beginning, we're already talking and said, we're very concerned about this child. We're going to do all of that, but here's what I want to do. But I want you to be aware, because we're really worried that he might be scared and he might need stem cell transplant. And remember, we talked about that. Sometimes they don't have any T cell, but sometimes they have the T cell from their mother. And so we check the quality of the T cell. And if there is any T cell, we really need to make sure that maybe it's not the baby, maybe the T cell are coming from mom, and that will have some consequences in terms of treatment later on. I think that's it.
And just one more thing, remember, we're spending a lot of time talking about SCID, and I know many of you may not have SCID. Many of you, your children may have something different like Wiscott or CGD or IPEX or some other immune deficiency. So although we put in a lot of things about what we would do for a patient with SCID, that doesn't necessarily mean that's exactly what we would do for Wiscott or for CGD. Those are a little bit different. There are prophylactic medications we give for patients with CGD. There's prophylactic medications we give for Wiscott, but the treatments are also different. And so although the SCID is probably our most severe primary immune deficiency, and so these are the most of the things that we would potentially do. Okay, let me see. So let's say we do determine it's SCID, or it's a Wiscott who has a really, really low platelet count and has frequent bleeding, or a CGD patient who has abscesses and infections. Then stem cell transplant is consulted to say, hey, we need to have a more definitive therapy. So what do? Well, the first thing we do is after we meet with the families, we request authorization to do HLA typing of the patient and any family member. And that includes the parents. Oftentimes people will say, hey, can I get tested my aunts and uncles and cousins and grandparents? And it's like, well, unfortunately, the best option available for somebody for a transplant is a sibling donor that's healthy who also doesn't have the same disease. And there is a 1 in 4 chance of any individual sibling matching your child. So you think, okay, they're the same kids, they should be perfectly fine. But I've had kids with 13 people in the family and none of them matched. And I've had people with one sibling, and luckily for them, their sibling matched. So it's very variable because each individual child has a 1 in 4 chance of matching. A parent is only a half match. As you can imagine, half of your child's DNA comes from one parent, the other half comes from the other parent. And so when we look at HLA typing, if there's a sibling donor and they're a healthy sibling, that's the best option we have available. Unfortunately, oftentimes that doesn't happen. If it's a patient like case number 1, where they're quite a sick patient and they really need to get definitive therapy quickly, then we may use a parent that's a half match because you're there. It's easy to get you. I don't have to do an extenuated search looking all over the country. I will still do that, but if I can get a parent faster and I need to go quickly, then that's what I would do. We would talk about all those options with you guys as parents as well. But the likelihood of family member, distant relatives and cousins and aunts and uncles matching is so much smaller than the current intermediate family that's why we won't really test them. Now, when we say SCID, there are hundreds of different kinds of SCIDs, and each one has probably a different therapy available. And we're in an era now where there are multiple different types of therapies that are available. The standard therapy is what's called a bone marrow transplantation. And with bone marrow transplantation, we would either give some kind of medication to suppress any abnormal immune system, and then we would get cells from the potential donor. And I'm not going to go into great detail about what that looks like in this particular call because it's very variable based on each individual patient. On the other hand, there are certain SCIDs now where people have worked hard to develop a gene therapy model. And that's available for things like ADA deficient SCID and X-linked SCID. And there's also one available for a RAG deficiency. So if you have if you have a type of SCID that has possibly treated by gene therapy, and it's something, then you should really get information about that. We have some available at our institution. Other institutions have ones available for different types of SCIDs. So we all know each other quite well, our SCID community. So it's easy for me to pick up the phone and say, hey, so-and-so, this patient has this kind of SCID, and you have the gene therapy available for that. I want to set up a referral and consult with you. Almost all of us are willing to do that because the primary thing we really focus in is the best care for each individual child. And the best care is really what the parents think is the best care too, to some degree. And we want to make sure you're aware of everything that we have available. So you should feel free to ask, and we're happy to set up the consults for you if it's something that's at the NIH or something like that that's different and I don't have it available. I will be happy to contact my colleagues there and try to set it up for you to meet with them. So that's what I mean by different types of SCID. There's some centers that have a type of condition, a transplant available where you don't have to give chemotherapy. You just give an antibody and then you do the transplant. They're available in 4 or 5 different centers, Stanford being one of them. And that's available for many of the different kinds of SCIDs. So everything is available potentially in the country, but it may not be at your local site. So we will work towards making sure you're aware of all the different therapies available. The distance to the hospital and the number of children in the home are really important for us to determine if you have to be, once you're diagnosed, you stay in the hospital, or whether you can potentially go home. So if you remember the case of number 2, where the patient was diagnosed on the newborn screening, he was healthy. He's perfectly fine. And so should he stay in the hospital and be in an isolation room in the hospital? That's what we used to do for every patient until they were old enough to have a transplant. Nowadays, though, sometimes the hospital is kind of not a clean, healthy environment for a baby, right? And it doesn't help your bonding. So what we've been able to do now for some of the families is if they're in a really protected environment and there's not too many kids in school, we sometimes will send them home and let them be really protected at home. And that's a lot of education we do with the families. That means that you can't have 5 children in kindergarten and preschool coming in and out of the house, because we all know that that's not exactly the safest environment. On the other hand, If you have a child and they're going to really go through and they're in high school or something, and they're really promised that they won't stay near the baby very much, or they won't be around each other too much, and you can really protect that baby, then sometimes we will try to let you guys go home until we can do the more definitive therapy. When we do a transplant, if we need to give chemotherapy, the baby has to be a certain age before we'll be willing to give chemotherapy. And the reason for that is the organs still have to develop and tolerate the medicines that we give. And so we tend to not give chemotherapy for babies unless they're at least 2 months of age. And that's probably the earliest that we would do a transplant. Gene therapy, on the other hand, it depends on the clinical protocol. None of the gene therapies for severe combined immune deficiencies are currently approved. They're all only available on clinical trials. And so each clinical trial has a specific minimum age before you can do that. Okay. Oh, I should have done this slide instead. Sorry. So as we talked about the bone marrow transplant, the possible therapies are bone marrow transplant, depends on the donor that we have. And the pros and cons obviously mean it requires chemotherapy to achieve full immune reconstitution. If you're really sick, like patient number 1 was, you may not be able to tolerate the chemotherapy. And then there is an option that we would do to try to just give you some T cells in order for you to get over the infection. And then we may need to do a second transplant to give you a full immune reconstitution. But that's something that we would talk about in greater detail. In gene therapy, it depends on the disease, the type of disease, as we talked about. And there are the other clinical trials, as I said, are antibody-mediated conditioning regimens, as opposed to chemotherapy, and reduced intensity, which means lower doses of chemotherapy, but chemotherapy nonetheless. And sorry, I jumped the gun. So here's how we're going to summarize a little bit. And there's going to be a lot of people on your team. And I think that's one of the big reasons why Allison asked us to talk to you guys. Who is the immunologist? Who's the stem cell transplanter? If you're in the ICU, you also have an ICU doctor. If you have a lot of respiratory issues, you also have a pulmonary doctor. If you have a really bad infection, you probably have an infectious disease doctor. And that gets really confusing because you just got a diagnosis on your brand new baby, and it's overwhelming. Being in the hospital is overwhelming. So the immunologist, as we talked about, initial diagnosis, the workup, the genetic testing to make that diagnosis, getting you started on prophylactic antimicrobials, the antifungus, antivirus, and antifungal medications. And they work with the infectious diseases to get the patient treated for that infection. The stem cell transplant doctor will determine the best treatment between stem cell, gene therapy, or enzyme replacement. And if stem cell transplant, then we're responsible for all the care of picking the right donor, communicating with the families about what that means, getting them, if there's gene therapy that they're eligible for, getting them for gene therapy. If it's something other therapy, going through all the risks and benefits of any type of therapy. If you're in the ICU when you're diagnosed because your child is sick, the ICU doctors are really focused only on getting you healthy enough to be able to be out of the ICU. For example, if you had that chest x-ray that we showed in the beginning, you're possibly on a ventilator. Their job is to make your lungs healthy enough to come off of the ventilator. You may still need oxygen, but you hopefully won't need a ventilator. And once you're not on a ventilator, you usually won't need to stay in the intensive care unit. Okay. And so they were really focused specifically on just that immediate infection and the health of your lungs. In terms of the infectious disease person, although everybody's interested in what's the disease and what's the treatment and when can the treatment happen, the infectious disease doctor works with us as a consultant primarily to help us find the best antibiotic. Some patients don't have a common infection in their lungs. They have potentially a very strange infection that are treated with different antibiotics than our standard medications. And so that's why we work with them. And that oftentimes will happen with patients who don't always have SCIDs, but some other primary immune deficiencies because they've been out in the community and they're diagnosed a little bit later, and they can get infections that are just more typical in those types of primary immune deficiencies. So we'll work with them to make sure they're providing or they're giving us the appropriate medications to treat the patient's infection. And those are the major 4 players that I see really being involved, except for pulmonary. Pulmonary really deals with the lungs. So let's say if your child was so sick they were on a ventilator, they may still need to be on oxygen when they leave the hospital, when they leave the ICU, the intensive care unit. And therefore, pulmonary will work with us because they'll need to keep monitoring them for their oxygenation and helping us get ordered oxygen for home, et cetera. Okay. When you're a new family, it is really hard to navigate a hospital system, especially if your child is sick. And if it gets confusing for you guys, one of the things I always recommend for my families, when I start seeing that there's too many things going on and they're getting different messages, I'll put a stop button on it and I say, hey, it's time for a care conference where all the physicians come together and we talk, and then we talk together to the family, because it's really hard for you guys to have to be the one navigating all of this. You should never, as a family, feel frightened to say, hey, can we have a care conference so I can understand everything about this, my child? And it's sometimes taking you away from the room, which is hard. Obviously, nobody wants to leave your baby, but sometimes walking outside of a room with all the providers together to go through what they're doing for your child, sometimes it's very helpful because it calms the situation and allows you an opportunity to really think about what everybody's saying. So I'm going to stop there because and let Allison ask us questions that she's hopefully seeing in the chat.
Yes, thank you so much, Dr. Shaw and Dr. Gurnez. This was amazing, and I'm sure, and I have heard that many people can definitely understand with seeing many various providers and care teams. It can get confusing. But we know it's all for the best for the patient. So I do have a couple of questions for you that I have come in directly from me. So the first one, somebody is asking, after treatment, so maybe after a patient has had their bone marrow transplant, how long does that patient need to follow up with all of the providers that you've mentioned? Is that something they do every year? For how long? How often are they going to be seeing their whole care team that kind of shepherded them through stem cell transplant?
That's a great question. And a lot of it is depends on the patient and the disease, et cetera. So first of all, you won't be following up with the intensive care unit. Once you're out of the intensive care unit, they're like, bye, good luck, come visit if you're after a while. If you remain on oxygen, we would still have you see the pulmonary doctor. And they usually see patients, if they're on oxygen, every few months. It's not as frequent, and hopefully everything is stable. So those are those two things. In terms of infectious diseases, if we've treated your infections, they won't need to stay involved. Then they trust us to be able to manage any prophylactic medication. So it's really during the acute infection period. In terms of stem cell transplant, so if you have a stem cell transplant, I see patients every single year, because after you've had your transplant, then there's also a long period called the survivorship program. We want to monitor, how does your organ function look after transplant? Are you growing and developing appropriately? How are you doing in school? Do you need special services at school? All of those things. And I do that for every transplant patient. So I see patients every single year, at least once a year. Just sometimes it's, hey, you're doing great, I'm so proud of you, no problems whatsoever, but here's the things I want you to focus in on, right? And other patients, they have issues that I need to continue to monitor. So therefore, everybody's seen at least once a year. After you have a transplant, the first 100 days or so is probably my most critical period. That's when I try to keep you still in a relatively isolated point. You might be home, but I don't want you going to birthday parties or going to Disneyland or any of those kinds of things, because that's too many people, and your your child's immune system may not be good enough yet. Okay. And that's hard, because it's oftentimes that people want it, especially right in this time of the year when it's Thanksgiving coming up and Halloween coming up and Christmas coming up. I'm like, you know what, you can do Christmas in July this year. It's more important for you to really stay with just the small little immediate family. Everybody else, every germ that everybody else has been exposed to is going to come to you. During COVID, everybody's been really used to being in isolation, which is hard, I know. As your immune system starts to recover, I start weaning your medications. And so the first year is really trying to get you off medications and making sure you don't have any complications from taking you off medications. After the first year, though, then I start letting you, kind of do other things. I might let you go to Disneyland if your immune system is really good by that time point. So those are the reasons why in the first year, I see you very frequently. And then the second year, those appointments start getting spread out to every 2 to 3 months or so. And then after that, it's every 6 months. And then I get to once a year, I'm going to see you. And during that 1 year visit, I will evaluate the lung function and the heart function and the hearing and the kidney function and then the growth and the development, et cetera. But most of the times we don't have you go back to immunology if you're a SCID patient and you've had a transplant. Now, if you're a patient with gene therapy, then it's a little bit different because it depends on the type of gene therapy. And because there's certain things we need to monitor in terms of your DNA. When we do gene therapy, we're changing your DNA and inserting a new gene into it, the one that you're missing. And when we do that, it's done in a laboratory. And sometimes that gene doesn't go to the place we want it to go. We need to monitor that that gene is still there. And where is it in your DNA? Your DNA is like this long. Whoops, sorry, I got that blur thing on. And if it inserts here, it does one thing. If it inserts here, it does something else. So it's the responsibility of the investigators. As I said, they're all clinical trials right now, but they need to monitor where that gene is. So you will be followed by the FDA rules for 15 years after gene therapy, because that is something that is still a relatively new procedure. And as I said, none of the SCID protocols are currently approved. And so therefore it is very important. We know what happens to children after they've had gene therapy, which means we need to monitor them closely for 15 years. And so I hope that answers all the questions. In terms of Wiskott and CGD or other immune deficiencies, again, it depends on what therapy we're talking about, but it's very similar to SCID that if your infections are cleared and your immune system is getting better and you're not having any other complications, then it's a once-a-year visit into the clinic to make sure that we monitor all the other organ functions and health of your child.
Wow, thank you, Dr. Shaw. That was very thorough. Kind of on that same line, we have a question of, you talked about patients with gene therapy are followed for up to 15 years, but what about for other patients? Is there, you both are in pediatrics. Can you talk about like the transition of care once somebody maybe ages out of your system, or does that not really apply when you're talking about rare types of PI?
So actually, can I start from the beginning?
Go ahead. You go ahead and start, and then I'll talk about the transplant ones.
Yeah. So for the one who, because not all immunodeficiency, not all patients with primary immunodeficiency, I mean, the treatment is not necessarily transplant, right? So some people cannot be transplanted. So it's very dependent on the institution you are in, but at least at Stanford, the pediatric side, so Dr. Lewis and I, Dr. Hernandez, Dr. Mikey, we follow kids and adults. So there is actually no transition. We keep following them from day one and, to the adult life. Yeah. And I mean, maybe from the, I'll let you go on the.
Yeah. And in terms of transplant, most of our kids are still transplanted as young children. So I will continue to follow you, although it gets spread out the older you are. Usually when they start heading off to college, I try to just make sure they're at least seen by a physician once a year. It's usually your internal medicine physician. Sometimes the immune system's not perfect. This year has been challenging because a lot of people have a good immune system, but not the perfect immune system. And so getting a COVID vaccine or getting an Evishield or getting something else has been a lot more challenging this year. And also the rules, or as you guys all know, are changing frequently. But for the most part, I will follow the patients up until I can follow patients up to 26 years of age, but most of the patients who are transplanted as babies don't need to see me at that age. And then I just refer them back to their primary team. But they have our numbers in case there's ever an issue that somebody has a question about. Because oftentimes, as you get older, you start having more questions, especially as when the child now takes care of their own medical health, right? And starts asking the questions. But I usually do a long transition period where I start getting when they're 18 to start thinking about their insurance. And I and thinking through what they need to look for when it comes time for their insurance. Thinking through, who they need to contact when they go off to college, especially, because in college, you usually just have the student health person who deals with the cuts and the falls and the coughs and the colds, and really thinking through what does that mean for that particular child.
Oh, thank you both. All right, the last question that I see that I have coming in says, how does this relationship work if a patient sees an immunologist in one hospital or state and maybe sees a transplanter in another because whatever they have is very rare, they live in a rural environment? How does this kind of work for that scenario?
Yeah, and the important thing is that we communicate. So you're right. People will come to Stanford and then eventually they need to go back to where they have a house and other children and a family, right? What we do is when you're getting ready to leave our institution, I send a whole big packet to that primary physician. Sometimes that primary physician changes or the insurance changes and you get a new primary physician, and we're always available to communicate with them. Sometimes nowadays, now with Zoom, I know how to do telehealth meetings and stuff so that everybody's together. And that's really important. I guess we found out how to do all this with COVID, but so thank COVID for one thing, right? We know how to set up a meeting with whomever. But we basically will still like to see you at least once a year. We understand that sometimes it's just not possible to get here. We understand that cost is quite expensive. So what we'll oftentimes will do is tell the primary team locally, here's the tests that we would like to monitor. And then sometimes I'll just do a telehealth to say, hey, these are the tests, I've seen them. Your physician has examined you and said everything looks good as long as there's no concern, but here's the things I want you to work on and stuff. Because we understand it's hard to, it's not easy to get on a plane these days. We understand everything is a little bit more challenging. So we also want to make sure that you're still getting the best healthcare regardless of where you're at, and we'll work with people with who to go to. And as I said, the primary immune deficiency community is quite small. We all know each other. So regardless of which institution, we'll work with your institution, and it may be you have to still drive an hour potentially, but you would be followed by potentially somebody locally.
Yeah, same for immunology. We have a lot of patients who are moving. Again, the one who cannot undergo a stem cell transplant, we communicate. I just received an email yesterday with a lot of medical record for one patient who's going to be transferring because the patient is moving, and we have email, we have Zoom. I mean, the most important, like Dr. Shah mentioned, is really giving the best care, and I think we can only give the best care if we know everything about the patient. So I think it's very easy these days to communicate over Zoom and email. So there is a lot of work that is going that patient might not see, but we want to do the best. So we'll be ready to see you.
Thank you both. And I think that's a good message for this whole session, is how communication is key, not just between providers and between institutions, but from the patient perspective. Like, share what you're doing with your provider if you're moving, if you're concerned about anything, or if you don't understand what's going on. That's how we all kind of work together and can provide the best care. So thank you, Drs. Shah and Gurnez. This was a really fantastic presentation, and that is also all the questions that I see coming in. I do want to mention Barb Ballard of Skid Angels for Life is saying that Skid Angels offers travel scholarships, which assists qualifying patients with the costs of getting to a long-term follow-up appointment. So if you live somewhere else and you see Dr. Shah and Dr. Gurnez in California, reach out to Skid Angels for Life, and they can certainly provide you with some travel assistance. And if you are tuning in today and you have SCID or Wiskott-Aldrich or CGD or Hyper IgM, we have some wonderful virtual exhibit booths from all of those foundations, which you can find on the conference platform, and you can learn more about all of them as you're navigating your journey with these rare conditions, as well as our SCID Compass program at skidcompass.org. So I just want to say thank you again, Dr. Shah and Dr. Gurnez. This was such a wonderful presentation, and we really thank you for taking time out of your very busy early California morning to join our PI conference today. That is all that I have for everyone this morning. So have a great rest of your day and a wonderful rest of the conference, and we will see you at our next sessions. Take care, everyone.
Thank you. Bye-bye.
Thank you.